So I'm going to offer a very warm welcome to Karen Welsh from the ICB, who's going to be talking to us about trauma-informed care. And I will share my slides, Karen.
Lovely,
You'll
thank
bear
you.
with me for 1 second. Now then, are you able to see those?
Yes.
Should I put it on slideshow?
Should I take control of it and then I can just do it from here?
Absolutely. If that's easier
Let
for
me
you,
do
more
that.
than happy to. Yeah. Are you okay with that now?
Yeah, let me just check. It will. Can I progress it? Yeah, it's a slight lag, but yes, that should be fine. Okay, so good afternoon, everyone. My name is Karen Welsh. Thank you, Liz. I'm employed by the safeguarding team at the ICB, but I'm based within the Violence Reduction Network team as well. My job title officially is I'm the Serious Violence Duty Coordinator for Lancashire and South Cumbria ICB. However, that doesn't mean I coordinate serious violence. That means the absolute opposite. So today, what I'm doing, and my training there says 2 hours. It is not 2 hours. It's about a 45-minute session. So what I'm going to do is give you a brief introduction to trauma-informed training and the Trauma-Informed Lancashire, what we've been rolling out for the last couple of years. Just see if that will no, that's not moving on. Okay, so the idea is, what is a trauma-informed way of working? So the trauma-informed approach looks at, we recognise how common traumatic stress or adversity is and the impacts of trauma and stress to everybody. When I deliver the whole day's training, we talk continually about, it isn't about them and us, it's about all of us. So it isn't just about the people we support, whether it's patients, clients, or whoever, it's about all of us because it impacts on our staff members, our workers, everyone around us, family members. So it's constantly about them and us. The idea of the trauma-informed way of working is we avoid re-traumatizing people. So if, for example, we realise that in some capacity when we're trying to help someone, we're actually causing them harm by re-traumatizing them, we try and do it differently. And it also means we look at how we do things. And if there's a better way of doing things, we need to be doing that. Trauma and adversity is incredibly common. Most people that you come across will have been impacted by trauma and or adversity in some capacity. Again, when we deliver the whole day's training, we look at some of the data and statistics. We also recognise that as common trauma and adversity is, we've also just come out of a pandemic, haven't we? The impact on COVID and what's happened to us as team members, as communities, as family, as a country has been massive, and it's so big that we probably won't fully understand the impact for years to come. So when we talk about trauma and adversity, we talk about the impact, but then we also recognise the impact that COVID and the pandemic has had on all of us. So one of the definitions that we use when we're thinking about what is trauma or what is a traumatic incident is this one. And traumatization occurs when both your internal and your external resources are inadequate to cope. So it's something more than it upsets us. It's literally your body and your mind, everything goes, yeah, no, I'm done. I can't do it. So it has a lasting adverse effect. However, we also recognise that it's very personal to us. One of the examples I tend to give is we were delivering training one day in person, and a car with 4 women in arrived and they'd had an accident on the motorway on the way to training. And 2 of the women came into the training room going, OMG, we've had this accident, we nearly died, I thought I was never going to see my children again. And they were up here and you could physically feel the stress on them. Literally everyone in the room was like, oh my goodness. And then the other two women walked in and they went, it was a minor bump, it was nothing. So the four women had been in the same car, they'd had the same experience, the same time of day, the same weather conditions, everything was the same, but two of them were up here stressed and the other two weren't. And so we think about why that might be. And in part, that might be because it's personal to us. Have one of those women experienced loss in a road traffic accident before? Have they known someone who's been significantly injured? Have one of them had a row with the partner at home that morning and they're already stressed when they got in the car? So there are all of these factors that potentially impact how we respond to a trauma or an adverse incident. So thinking about that, I know there are not many people on the call at the moment, but what do we think a traumatic or a adverse childhood experience is? Any ideas? You can either shout out, take yourselves off mute, or put it in the chat if you want. Anybody?
Go on, I'll jump in. So
Thank you.
loss of a parent, or death of a close family member.
Lovely, thank you for that. So when we talk about death or bereavement, we absolutely acknowledge that that can be a traumatic event. If we think about a sudden death, loss of a child, loss of a parent, loss of a loved one, absolutely. However, what we also think about is if your 99-year-old granny dies peacefully in her bed after a long and prosperous life, surrounded by all of her family, is that necessarily traumatic? And the answer is no, but it might be. So when we think about death and bereavement, it's a yes, but. So if your 99-year-old granny is your one safe person in life, if they are the one person who's loved and nurtured you or looked out for you, her dying could be incredibly traumatic for you, but for other family members or other friends, it might not be. So we think it's about a yes, but. Again, I see someone's put in the chat, abandonment, breakdown in relationships and things like that. And again, we think, is a relationship breakdown always traumatic? Well, absolutely. If we know that someone doesn't want that relationship to break down, if we know that there are children involved, the family network breaking down absolutely can be traumatic. However, I have also been on training where people have said, my life improved dramatically when they left. So we recognise that family breakup can be a yes, but as well. So I'm just looking at some of the chat. So illnesses, I absolutely think things like a life-altering illness can be incredibly traumatic. So not only for that person, but for loved ones as well. Is it Susan has put bullying in there? What I find really interesting, and I'm really sorry, I didn't do my sort of full introductions really. So my background, my degree was criminology. I was substance misuse practitioner. And then I ended up working in education for 10 years. And I was the DSL in school, so in charge of all safeguarding and child protection. I've been delivering the trauma-informed training for probably 2.5 years. And nearly every single session, when I deliver the training, someone talks about being bullied and the negative impact it has, it's had on them for their entire life. So we have grown-ups on the training talking about the impact of being bullied at school. Now, when I look back on my 10 years working in education, did I realise the impact of bullying? Absolutely not. If parents came to me and said the child was being bullied, I would be like, well, maybe they've just had a bit of a fallout. Oh, I'll get them together at lunchtime and we'll play dominoes. That'll fix it. If I knew then what I know now, after we've delivered this training, full day's training to over 12,500 practitioners, and most sessions, someone talks about the negative impact of being bullied at school. So I wish I knew then what I know now, and I'd have done that very differently. So being bullied absolutely is really significant when we think about trauma. It has an impact on your self-esteem, on friendships, on academia, on job prospects. So it's massive, and it's something we haven't always thought about. So to go back to the list that you put in the chat, domestic violence, absolutely. We know any form of domestic abuse, whether it's violence, whether it's coercive control, whether it's gaslighting, whether it's manipulation, all of those things can be impactful. Addiction, and can I say very well done for everyone in the group. We don't normally get this many shout outs when I've got a room full of 20 people, so you're doing very well. When we talk about addiction, because I had been a substance misuse practitioner, I'm very, very empathetic to people struggling with addiction. And when we think about people who, nobody wakes up and goes, oh, you know, when I grow up, I want to be a heroin addict. Oh, when I grow up, I'm going to try and destroy my family by drinking too much. Absolutely not. And what I say, in my opinion, in my years being a substance misuse practitioner, I have never met anybody who's struggling with addiction who hadn't suffered trauma. So for me, if we recognise that someone who's struggling with addiction, if we replace the term addict and replace it with someone who's trying to numb pain, because most people who are struggling with addiction are trying to numb pain in some capacity, and they use, whether it's drugs, alcohol, gambling, food, whatever they're using, they're trying to numb pain. And then if you take that step back and look at going, what's happened to them for them to be in pain, it just helps us to be more empathetic and more kind when dealing with people with addiction. So there are loads of different ideas around trauma and adversity. And we've, again, in the chat, we've got mental health issues. Absolutely. We've got different aspects of conflict. Yes. Any physical or remote threat. So there's loads, aren't there? There's absolutely loads. Over the last 10 or more years, we've looked at adverse childhood experiences, and the idea of that is they are developmental traumas that happen to someone up until the age of their 18. When we think about trauma and adversity, it can happen to anybody at any point in their lives. So we know the adverse childhood experiences, we look at things like your physical abuse, your sexual abuse, and having a parent in prison, being around domestic abuse and things like that. But the idea that the trauma or adversity happens at later life. The idea of the, sorry, I can't remember what my slides are there. The idea of the, oh, I'm going the wrong way. How do I go backwards? It's okay, we'll manage. So the idea is the adverse childhood experiences either are indirect or direct regarding children. So the direct traumas are things that happen directly to them. So your sexual abuse or your physical abuse. Your indirect that are still really, really harmful are things like having a parent in prison, having a parent with really poor mental health, and things like that. When I worked in education, I used to get police reports through. And if the police had attended a significant domestic abuse incident from one of our families, I would get a police report through that said, police attended significant domestic abuse incident at, you know, the Smiths family house last night. Children in other room unaware. Now, do we think if the police have attended a significant domestic abuse incident, that if, because the children are in the other room, that they're unaware of what happened? And the answer is no, of course they're not. Because even if they haven't witnessed violence, they hear the violence. And sometimes hearing violence can be more traumatic than seeing it, because when you see it, you know what's happening. When you hear it, your mind runs wild. But even if children don't see it, don't hear it, they feel it. So if you walk into a room after a significant incident's happened, you just know, don't you? You just know that something's been going on. And again, thinking about this slide here, what happens to your body during a trauma or stress response. And it's not a choice and you don't think about it, but it happens instantly in a split second. So your heart might start pounding, your breath might become laboured, you get sweaty palms, you get tunnel vision. You might get a dry mouth because your digestion turns off, because you don't need to digest food in a life or death situation. So all of these things happen really, really quickly. And when we're around people, sometimes we can notice some of those physical things happening to them. Again, when I reflect back on working with people, we used to have people who constantly wanted the toilet. Or, when I worked in education, we'd have children come into me, Miss, I've got a funny tummy. And never at any point did I consider that they were going through a stress response. If teenagers were coming to me, Miss, I need to go to the toilet again. Well, you can't because you've just been. Or you're just trying to get out of class. So we used to think that it was an alternative reason, but we never considered it was a stress response. And for me, again, it might make me sound like a really bad practitioner every time I say this. When I look back, I wish I knew then what I know now, because every time a child came to me and said, Miss, I've got a funny tummy, if I'd have thought, gosh, I wonder what's happening in their world, what's going on with them for them to be having a funny tummy. Why are those young people or those teenagers constantly asking to go to the bathroom? Is it a stress response? When you see people tensing or bouncing, again, it's like, gosh, I wonder what's going on with them. All of them can be a sign or symptom that they're having a trauma or a stress response. We also know, do you remember years ago when people used to say, oh, you need to get rid of that stress in your life, otherwise you're going to have a heart attack? We sort of know it to be true. So we know that the impact of trauma and stress has an impact on our physical health as well. I've got autoimmune issues and I've got skin complaints. Without a doubt, over the last 30 years, I've got psoriasis, for example. My psoriasis flares up at times of stress. In my 30 years of being under consultant care or my GP, the amount of times I've gone to the GP or the consultant having a flare up, how many times do you think I've been asked about stress? None. Absolutely. I know that my symptoms are worse during stress. So what happens when I go to my doctor having a flare up? They give me a cream to treat the flare up. They don't look at the cause of the cause. Never has anyone said to me, how's work? How's home life? How's your world going on? Because if you're stressed, it might be a cause. They just treat the cause. And so that's something that we need to be mindful of as well. I personally know people who have tried and tried and tried to get pregnant. They've tried all sorts. They've tried alternative medicines, they've tried herbs, they've tried IVF, and they've not been able to get pregnant. And they've tried for a very, very long time. Eventually, they give up and go, right, yeah, it's just not meant to be. So they end up buying a dog or something, and then they get pregnant. So the sort of getting rid of that stress and anxiety around can have a massive impact on your reproductive system. I co-deliver the training, or I have done for the last 2.5 years, with a clinical psychologist. Sometimes he'll phone me up and he'll go, oh, Karen, my back's gone. I'm on the floor. I've not been able to get up for 6 hours. And then 24 hours later, he phones me and he's all better again because he's delegated. He's got rid of all of his stress. He's got rid of some of his workload. Again, when I worked in substance misuse field with people struggling with addiction, grown-ups, loads of them had bad backs, bad joints, bad legs, bad whatever. So we know that all of these things can have a direct impact on our physical health if we don't get support around trauma and stress. In the full days training, we go into a lot more detail around data and statistics and how much likely you are to have things like heart disease or respiratory disease, how many times you're more likely to choose a GP appointment, etc., if you've had trauma in your life that's unresolved. So why does it matter? Well, of course it matters, because we know some things we've just talked about. Trauma and adverse childhood experiences, or any form of sort of stresses and trauma in your life, can have that negative lasting impact on your physical health, your mental health, and your social outcomes. We know that one of the strongest indicators of someone getting over a traumatic experience is a positive relationship. having a safe grown-up or a safe person in their life. So relationships can be key. And we don't mean necessarily being married to someone, it's just literally someone who cares, or someone that they can check in on. When we talk about trauma and adversity, we think about scales. So I don't mean the scales that you stand on in the morning in the bathroom to see whether you've lost weight or put a bit of weight on. The old balancing scales, as the diagram shows. And when we think about the scales, we can't, if someone has had bad things that happen, so trauma, adversity, scary things, bad things that happen, your scales can tip, and that's when people become overwhelmed. And it's not easy to fix that or remove that, because without access to really good psychological therapy, and we know that's not easy, so your scales can tip. But what we can all do, from a professional point of view, from a friend point of view, from a colleague point of view, from a family point of view, we can all add to the other side of the scales. So having a safe grown-up, as I've said, having friendships, having somewhere stable to live, having access to the outdoors, having access to education, all of those things can help the scales tip. And that's when we don't become overwhelmed. So having your resilience, all the positive factors on the other side of the scales, can help balance it out. When I talked about the women who arrived in the car, 2 of them were stressed like mad and the other 2 weren't. The 2 that were stressed were obviously missing something on that side of the scales that day, or generally. And it's something as simple as having friends to talk to, having someone who cares about you in life, having some stability can make a massive difference. When we think about who we work with and who our teams come into contact with, I'm really, really mindful that all sort of behaviour is communication. So however someone is reacting, it's all trying to tell us something. So on the slide, it says how we respond to trauma is sort of unique, isn't it? So we might see someone who's really angry. We might see someone with poor self-esteem. We might see someone who's really anxious and, doesn't dare speak up. We might see people who are shameful. And we know things like shame and embarrassment is one of the strongest indicators of not getting over trauma. If people feel ashamed of what's happened to them, whether they're at fault or not, it's a strong indicator to them not getting over the trauma and adversity and it being impactful for a very long time. So what we see isn't necessarily what we get. And I can't remember if we talk about... so when we think about professional curiosity, and I always link this into that shame and embarrassment. So if you're working with someone and if they're telling you something that you don't think is quite true, it's about thinking, right, well, why might they be telling me that? And it's not because they're liars or they want to deceive you or there's any really bad ulterior motive. They might be really embarrassed. I've worked with loads of mums, for example, who are not meant to be with abusive ex-partners. And when they come into meetings with me, oh, no, I'm not with him anymore. But I know he stood by the door. So it's like, why would mum be telling me she's not with that man anymore, yet he stood there? She might be embarrassed. She might be ashamed. She might be worried about professional involvement. She might be being controlled. She might actually think if I leave him, he might injure me or the children. So professional curiosity, the capacity and communication skill to explore and understand what's happening within a family or with an individual, rather than making assumptions or accepting a version of events at face value. So it's almost like your spider senses. If someone tells you something, you're just like, I wonder why. I wonder what else might be going on. And like I say, it isn't necessarily that they're deliberately deceiving you or telling you something really bad. It is literally, it could be embarrassment. It could be totally, they're ashamed of where they're at. But just being able to think, what else might be going on is really significant. And also, we tend to not ask questions because we're worried about opening up that can of worms. Oh, what do I do if someone tells me something and I don't know what to do with it? Ultimately, there is no can of worms because they already know their information. The can of worms is from our point of view, isn't it? It's like, oh gosh, what do I do with it? But we don't have to worry about them because they know what's happened to them. Language is so important. So when we try and, if someone says to you, what is wrong with you? What is wrong with you? What is wrong with you? It's almost an accusation, isn't it? There's something wrong with you. If we're saying to someone, what's happened? What is going on in your world? It's a very different question. I have absolutely said to my children at some points, you know, flipping out, what's wrong with you? Why are you whining? Stop it. But if you go, right, what's going on? What's happening for you to be screeching nonstop? Or when you're speaking to someone, what's happening? Tell me what's going on, which is why you're in this situation. Language is really key. It can be so negative, or it can be really empathetic as well. When I've worked in safeguarding over the years, I've been called to court a couple of times, and one of the times I got called to court about some safeguarding notes, and it was about a family that we'd been involved in, and the judge said to me, you've documented, you, not me, but the school, you've documented that this parent was being aggressive. What were they doing? And I was like, oh gosh, I don't know. And so the term aggressive means something to me, and it might mean something different to you, and it might mean something different to the next person. So also at the same time, the judge said to me, you've written that this young person was upset. How do you know? And again, I was like, yeah, I don't know. So I had to go away and we rewrote the how to record and report policy, because saying that someone is aggressive means nothing. Because to me, it might be someone banged on the table. To someone else, it might be they ran at them and wrestled them to the floor. Saying someone's upset might mean they're stifling a sob, or they might be laying on the floor crying hysterically. So we had to rewrite our policy we didn't use overarching terms. We started writing what we saw. So the man was leaning forward, raising his voice, clenching his fists. That's what we would write about how someone presented. The young person was sat on the floor, curled in a ball, crying and shaking, rather than saying they were upset. So if we say what we see, as opposed to using terms, it makes it a lot easier to do. In the same way, attention seeking. What does attention seeking mean? So attention seeking behaviour means that someone is trying to tell you something. Someone's got unmet needs, haven't they? That however, they're seeking attention and they haven't got it. So attention seeking behaviour could be attention needing behaviour. Or they're trying to tell you something and you're just not listening. So it's really, really important that when we see someone, and again, it comes down to that all behaviour is language, isn't it? They're all trying to tell you something. So if someone is being aggressive, what does that mean? If someone is attention seeking, what are they seeking? What are they actually trying to tell you? And again, when we look at people who've talked about suffering trauma, adversity, and whatever, they will say, no one ever asked me. They just responded to my negative behaviour. So it's really important that we think about language that we use. So what does aggressive actually mean? And it's really important. So when I go and train staff on the wards, I always say to them, if someone documents in the handover notes, patient in bed 3 was aggressive. Staff coming into shift, they read those notes going, all right, patient in bed 3 is being aggressive. Right, 2 of us will deal with them today. We're not taking any of their nonsense. If we say patient in bed 3 is really dysregulated, they're really struggling to contain their emotions, they're frightened and they don't understand why they're here, that helps us to be more empathetic, doesn't it? And it's very different saying someone is really struggling to contain their emotions or someone's being aggressive. Again, in the full day's training, we talk about victim blaming language and how we should be avoiding it. And just things like when I was putting all the slides together for the full day's training, there was loads of headlines on social media, in the news and whatever, and just examples of man murdered his nagging wife, which suggested had she not been nagging, he may not have murdered her. So it was sort of her own fault, wasn't it? Woman was raped at a man's flat after she drank 10 glasses of wine. What does how much alcohol she's consumed matter if she's been raped? So victim blaming language is really important. And like I say, we do a lot more in the full day's training about language. So we just need to be mindful. And also, just on a side note, we know that whatever we document nowadays, people have got a right to see. So it's really important that we don't document anything that we wouldn't want someone to read. I follow some people on social media who are social workers, and yet they used to be looked after children. And this one social worker in particular has had access to her notes from when she was a child. And she shares some of the stuff on Twitter and things. And when she was 13, I think it was, she was removed from her mum's care. And the social worker at the time had written, this young person is, her behaviour is disgusting and she's not bothered. She's uninterested and whatever. And this social worker reflects back and she's like, oh my gosh, that was the worst day of my life. And that social worker has described my behaviour as disgusting and that I'm uninterested or whatever. She said, I was in shock. And also, in one of the reports that a social worker had written about this when she was a child, the social worker had misspelt the girl's name 37 times in one report. And this social worker is going, she didn't even care enough to spell my name right. So it really matters how we document things. So trauma, absolute common human experience. It happens to everyone. It's not about them and us, it's about all of us. Being trauma informed means being kind and empathetic. So it's really important that we try and be kind at all times and bring our human to work. And it sounds like a cliche, it sounds ridiculous, but bringing our human to work is really important. Can we show the Brené Brown video now, please? If I stop control.
Super. I was panicking that I couldn't get off mute.
Yeah. If we show the quick video,
yeah,
and
absolutely.
Then I'll see if there's any more questions, and then before we carry on.
So let's play this.
So what is empathy, and why is
Can
it
you hear the sound?
very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you can climb down. I know what it's like down here, and you're not alone. Sympathy is, it's bad, no. You want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with "at least." Yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Thank you. So the only other thing I have for you today is to show you another little video, which is the opening doors video. Are there any comments or questions at this point? Just to say about that little video then, I love that video, and it really sort of resonated with me because I hadn't realised I was a silver lining sort of person. I'm a doer in life. So if my friends used to come to me and say, oh, you know, life's awful, I've fallen out with my husband, my kids are driving me mad, whatever, I'd be like, right, let's make a plan. What can we do? Why don't you do this? And why don't you do that? And why don't you do the other? And eventually one of my friends said, Karen, I don't want you to fix it. I just want you to listen. And I was like, oh gosh, that's a bit tricky. I don't do that very well. And so I had to really sort of reflect on what I did as a friend, as a family member, but as a practitioner. And if people came to me or if I was aware of things, I would want to try and fix it or do something. And it took me a long time to be able to go, gosh, you know, thank you for telling me. And that's awful that you're going through it. And very often, when I said before about sometimes we're worried about asking people questions in case we open up this can of worms, predominantly, if people tell you something, one, they want you to believe them. Two, they want you to acknowledge that, you know, it's really bad what's happened to them. And three, if there is any support you can offer, great. But if not, you don't need it. So it's literally about, you know, thank you for telling me. I believe you. And gosh, that must have been really tough. And very often that is enough. People don't want you to fix it. They don't expect you to fix it. They literally want you to believe them, be empathetic, and acknowledge what a really hard time they've had. I'll just check, are there any questions that anyone wants to ask? I don't think there are any in the chat, are there, at the moment? No. So what we'll do, we'll just watch. Again, if this is okay, Liz, we'll put, oh, yes, Susan, you've got your hand up.
Yeah, it was just a comment, really. I mean, it has been really helpful, some of the tips you've given around this, and it was making me think in particular about when you're supporting the family of a person who we might be supporting. So it might actually be the family member who's had that adverse childhood experience, perhaps from the person who you're supporting.
Yeah.
And you know, it might actually be that there's things that trigger their behavior, and you know, I'm thinking particularly people who are managing care homes where family members might not be behaving in a way that, you know, makes them feel that residents might be at risk, or, you know, staff might be at risk. But actually that might be to do with certain triggers that if you could get to the bottom of it or find out a little bit more information, might help manage those relationships.
Yeah, absolutely. And it is understanding the cause of the cause all the time. So if someone is coming in, you know, kicking off, shouting at you, complaining about whatever, sometimes sitting down with them going, right, let's have a look at what the problem is. And it might be, do you know, I had a really interesting conversation with someone from MWAS the other day, and she was saying to me that she's doing some work with the call handlers about dealing with aggressive patients and stuff on the call. And she was telling me that when she was pregnant, her first pregnancy, she went into labour at home, she was by herself and she was bleeding, and she'd phoned the ambulance and they didn't come. So she said, I phoned the ambulance again and I behaved like a lunatic on the phone. I was like, you don't understand what's going on. And she was shouting and screaming and whatever. And so she understands that sane, rational people, when they're frightened, when they're scared, when there's something going on, they behave in a manner that you wouldn't normally behave in. So sometimes people are, because they're frightened, because they're stressed, because you don't understand the situation, the way that they demonstrate all of that is by becoming more difficult or challenging. And then if you resolve a problem, that's when they normally go, oh, yeah, sorry about before. I didn't mean to, I didn't mean to raise my voice, but I was just up here. So yeah, very often just being able to give people the space and the time to say, what can we do? What are you worried about? What are you frightened of? Will be a massive, massive help. Thank you for that, Susan. Anything else before we watch the video? No? Lovely, Liz, are you okay to show that? And then
Yes,
after the video, we'll just have, another minute or two to wrap things up. Do you want to maybe full screen it down there, Liz? Next one. This one.
Is that working now?
No, I think you've pressed the wrong thing there.
Press the wrong thing, sorry.
Yeah,
this
right.
one.
Yeah. I have no sound at the moment. I don't know if it's coming on.
Apologies. Don't know why the sound isn't playing.
No, IT, always an issue.
Let's just check. Oh, right. I think it's just very quiet.
Listen, if it won't play, it doesn't matter. What we can do, we can send it out to people. It's about 7 minute long. Yeah, if that, look, let's not bother with that, Liz. Let's just stop it.
Apologies for that. I don't know why it was so quiet.
We can send it out to everyone, and I think the idea, what the video does, it's NHS Scotland. They pull together the idea of working in a trauma-informed way, and it's about listening to the people we work with, empowering them where we can in a proportionate way. So, for example, if somebody says they only want to deal with a male worker, for example, and if we don't have any male workers on that day, what do? We listen to them, we empower them, we acknowledge what the requests are. If we don't have a man on, we say, well, would you like to be seen by a female, or would you like to come back another day? So we do listen to and we empower as much as we can, but it's got to be proportionate in what we do. Again, in the video, it shows if someone goes to the dentist and the dentist says to this young person, how will you let me know you want me to stop if it gets too much for you? And again, that's just really nice and something really simple. And can I just say, my dentist doesn't do that to me. But so it's just about, if you are doing something with a person, just making sure that they're okay. And, if you want me to stop, how will you let me know? Little simple things can make a big difference. So the idea of today is an introduction to what is a trauma-informed training. The training is up to a full day, and I know it's a discussion we'll be having with Liz and Lisa going forward. If there's an interest, there may be the opportunity to have further training into the new year at some point. Are there any questions or any comments anyone would like to make at this point?
If there's nothing from anybody else, I just want to express huge thanks, Karen. That was such an informative session, and
whistle stop tour. I'm afraid it's
so much
really
experience that you brought to that session. It's absolutely wonderful. Thank you so much for joining us. Does anybody have any further questions or anything that they'd like to add?
No, I thought it was really good, Karen. Really, really,
thank you.
Interesting. Yeah, excellent.
Like I say, whistle stop tour. We're just literally covering the slight little bits today. And if you are interested in further training, please do, ask and talk about it. And if we've got capacity to, we'll always look at coming back and doing more in the future.
That's so wonderful, Karen. Really appreciate that. If there are no more questions or comments, all that remains then is to say thank you so much for joining us. I know numbers have been small, but that's been such a fabulous session, and I think a lot more colleagues will benefit from it on our Bite-Size YouTube channel as well.
Amazing.
There was a quick question there from Gillian. That is, do you have any resources available for trauma-informed care with residents with dementia?
To be honest, the thing with what we find with dementia patients, do you mean to reduce the risk of violence or engaging with them, or what is it you mean, Gillian?
If you can chat, please do come off mute, but if you're unable to, if you could pop something in the chat.
Or if not, pop a message in or drop Liz or whoever a message, and if there's anything I've got I can think of, I'll send out to you.
Oh, that's brilliant. I will pop my email address in the chat now.
Lovely.
There you go. Gillian did pop an answer in there.
Oh.
General practice when it's a word I can never say it, cognitively impaired.
Usual conversations. Yeah. I mean, to be honest, and when we think about dementia patients, when we know what we know about dementia, and I am absolutely not a specialist in that field per se, we know that very often it's recent memories that go on. My husband used to train in Dementia Friends, and he used to say, imagine you've got a bookcase and all your memories are in this bookcase. When you've got dementia, the bookcase wobbles, so all your most recent memories fall off and all your memories down here tend to stay the same. So if you've got the ability to talk to them about the childhood, if you've got their ability to talk to them about what they used to do when they were growing up, what things they used to do when they were, teenagers, or those are the sort of memories that very often are the last to go. So if you can engage with them in that capacity, it's just something that you've got almost a safer bet. If you talk to them about what they did last week, very often they don't know. My mum had Alzheimer's, and it was, my mum didn't know my name for a long time, but she could recite a poem that she learnt when she was at school. So again, if you ask them open questions, ask them about their life, things like that, they can very often sort of talk to you about more than current things. And what I'll do, I'll ask around the team, and if we've got any other resources, I'll send them out to Liz, and Liz can distribute them as well.
I think it's really good, and I think it's a really good question, and it would be really helpful to have some resources because, and I think the question is a really good one in the sense that you don't know sometimes whether you're opening a can of worms, and it comes down to the sort of care planning of something. But I think if you still work on that kindness, empathy, and compassion, you're not really going to go wrong with a lot of things. So that would be my
Yeah, thank you. And it's, do you know what? Everyone who works in this environment works in a really tough field, don't they? It's really hard working with people. And again, one of the themes of trauma-informed training that we do constantly throughout the whole day's training is we need to look after the people who look after the people. Because if we don't look after the people who look after the people, we end up with a burnt out workforce. We have staff who leave, we have staff who are not, compassion fatigue, or they're exhausted. So it's really important that where we can, we do look after the people who look after the people.
Yeah, good point.
Absolutely. Really good point.
Yeah.
Really nice to see everyone, and thank you ever so much. Liz, I'll stay on for a minute after everyone else has gone if you like.
Thank you, everybody. Really appreciate you joining us today, and fabulous session there from Karen. Thank you so much. What a fantastic session that's been.
Thank you.
And I'll
Really
send out the slides and things for you once my IT gremlins have gone. So we'll be sending it out. Okay. Thanks, Angela, Sue, and Gillian.
Thank you, everyone.
Thank you.
Peace.